Much with it. We have our final panel that I'll ask to come up. So thank you all. We appreciate it. Our final discussion today and at the summit is on the disability and mental health needs of incarcerated people. We'll ask our panel to step forward. Also, our county treasurer is here. There she is. Yep. Hey, Erica. Thanks for stopping in as well. We appreciate it. Okay, and those who were with us earlier today know that we did talk a little bit with the new county executive, Sarah Namarato, about the county jail, some aspects of that. And look, we were very glad to reach out and talk and to build a discussion around the behavioral health needs of incarcerated people. It is a topic that has been a little while since we've gotten to, so we're very glad to get back to it. We really appreciate Lou Randall helping us get this team together. So we thank everybody for being a part of it. We're going to keep moving just so we can keep on target here with the day. So just let me be sure to introduce our speakers. Lou is the executive director of Autism Connection PA. She's been there since 2010. She speaks extensively in all areas of autism life, including school to work healthcare, victim services, and law enforcement continuing education. She's a member of the Office of Developmental Programs, Information Sharing and Advisory Committee, the Pennsylvania Commission on Crime and Delinquency Victim Services Advisory Council, and the Allegheny County Autism in the Courts Work Group. So thank you, Lou, and again, we thank you for all your work. And sitting right next to Lou, to her right, is Lee Owens. We very much appreciate Lee being here. He's the Director of Education and Advocacy of the Pennsylvania Prison Society. The PA Prison Society supports incarcerated individuals and their families, engages in education and advocacy, and monitors conditions in our prison system. So thank you as well. I would note, I think we were supposed to have a speaker from the state on this too, right? Yeah, I think, and then they got sued. So I think that's what happened. So we can't do that. So we're going to do the best that we can without that representation. So we'll find another way to hopefully address that, and we're going to move forward. Lou, you up first? All right, thanks. Lou, go ahead.
Didn't select that. Oh, there it is. I saw the light, but it wasn't that bright. Anyway, what Dan said about me is true, but everything I've learned about autism and autistic people, I've learned from autistic actual people. Working in homes, I have a master's in rehab counseling, so I know a lot about brain and neurology and that kind of thing, but really working in people's homes of people when I was at TSS way back in the day and following them through adulthood, which is leading a lot of people into jails and prisons, and I think just naturally flowing from our previous presenters, where people are when they're on a waiting list sometimes end up in our county jails and prisons, in our state prisons. So this is sort of a natural, unfortunate continuation of that. So yeah, I lead the Autism Connection of Pennsylvania. We're statewide. We have about a 20,000 person constituent list. And we started with parents meeting in each other's homes for support and have grown to have a board that's heavily represented by autistic people. My closest colleague is autistic. She just got diagnosed recently, which is very exciting. And I feel very gratified that I made a good hire a couple years ago. And so we're all about the autism. Dan asked me the first thing you asked me to talk about, and also thank you for having this and thank you for your time, is why are we here? That was the very first thing on my list. And when I looked at that question over and over, I thought about the times I've spoken in county jails and in state prisons and in meetings and hearing staff over and over saying, why is he here? Why are these people here? This is not what we're built for. This is really not the purpose of, not why I came to work. People feel like this is no place for people with disabilities, not just autism. And we talk about autism, we talk about intellectual disability, we talk about mental health conditions. They really all overlap. I've rarely met a person with different kinds of developmental disabilities by adulthood that doesn't have an anxiety disorder, a panic disorder, a PTSD, anything like that, depression. So we're really here to represent and all these people. People feel ill-equipped when we go out and do trainings. I mean, we're out there teaching people about really complicated neurological disorders. I always need to say that autism is a medical condition. What's interesting about it is, I'll go that way for 1 minute, people who are autistic have extra nerve cells in their brains, which can create lots of like creative thinking and a lot of divergent thinking, but it can also kind of make a traffic jam. And I had the pleasure yesterday of coming in and driving with somebody who had his brain studied at Pitt and finally found out that when he goes into a bathroom and sees certain patterns of tiles on the floor, that shuts his brain down functionally for a period of time until he can set that straight again, and he couldn't find his way out of bathrooms, and he's in graduate school. He finally found the medical evidence for him of how his brain sort of freezes up that way. Imagine that person going into a correctional facility, having a police interaction, having to respond quickly to commands or whatever. It's just physically sometimes, literally physically impossible. We just can't see that on the outside. So people are in our jails and prisons. I'm really here to ask you to continue this conversation. This is a beginning to talk about diversionary programs. I find it really interesting that a person, I can be drunk driving today and go into a 30-day program for rehab, but I cannot be born with a different brain and have that opportunity or that choice. I can go directly to jail. And if I'm in jail and I'm autistic and I can't respond quickly to a command, I've seen people on their records be put into solitary confinement because they turn their television off quickly enough. I've seen people put into solitary confinement because they defended themselves and spit at somebody. One of the things I read was pushed his tray forcefully through the slot. So being put into solitary confinement with any kind of difference, disability, especially mental health conditions, especially the people that can get into their delusions too much, the worst thing you can do is leave them alone, especially for 30 days. We wonder why people come out mentally ill, damaged, and just worse than they went in. It's not a new problem. I'll talk about statistics. I did write a grant once. It was sent back to me by the funder that said I was too humanistic, so I will ask you to be too humanistic right now. But I'll read you some statistics anyway. The Department of Justice states that 64% of people in our county jails nationwide, 54% of state prisoners have mental health concerns. If you don't go in with one, it's pretty much known that you'll come out with one anyway. Over 500,000 people are incarcerated with intellectual disabilities nationwide. Over 500,000 people are in. I was on the phone today with someone from the DOC in Harrisburg saying they're seeing a lot more people with much lower IQs than they've seen before. So we talk about the service system and the waiting list and all of that is flowing over. I've worked in disability for 30 years. I think people are very proud that we've deinstitutionalized people, but I will tell you, I think we're reinstitutionalizing people in the institution of prisons. And we need to sort of absorb that and then continue to work against that trend. There was a study done on 1,800 prisoners in a Midwestern prison and found that 4.4% of them are autistic. Again, one of my favorite topics. By that metric, we should have 1,628 people identified in our state prisons right now. I know 51. That's 50 more than when we asked in 2019. So there's been progress in screening people going through Camp Hill. There's been some progress in identifying people. Right now, honestly, it's felt very word of mouth. We've set up this neurobehavioral unit that Rep. Bennett and I got to visit. We set that up, help people, and they were very open to consultation at the beginning, which was great. It was I thought that was pretty optimistic on my part. But we're just really far behind in terms of identifying people that way. Part of that, again, you've heard, there's a waiting list in community mental health, community medicine. So this all kind of flows together. Meeting Tuesday morning with Allegheny County Jail, because at the county level, we don't ask the question, has anybody ever told you you're autistic? And it's like the only medical condition I can think of that people balk at that. And I think that just adds to the stigma. Why are we afraid to ask people if they have this medical condition? It shouldn't mean anything negative other than they get different kinds of communication. I mean, some of the communication I recommend when I'm teaching people is a Post-it note to remind somebody to do whatever it is that they need to do. It doesn't have to be fancy or expensive, but we need to start asking at the county jails, has anybody ever told you you were autistic? And then let people do a screening tool to find out, so that when they meet the judge the first time, if they tend to look down, because their eyes are connected to their anxiety center, and that's why a lot of people can't look people in the eye. They're not seen as belligerent or non-compliant or rude. If somebody had a screener on their intake to the jail and they said, maybe something else is going on, then we have more opportunity to help people versus imprison people with disabilities. So we're behind as a disability in terms of lots of things. I've been, like I said, I've visited the NRTU. It's the Neurobehavioral Residential Treatment Unit at Albion. There are about 45 people right now there with autism. When Rep Bennett and I walked in, people flocked up to us. I don't know how many people said, I want to be like you. I want to help people. Can I be an advocate? That guy can't read. That guy doesn't know why he's here. And that guy doesn't know who he is. So I want to say for our autism moment of the day, people with autism are extremely empathic, and sometimes so much so that they shut down and can't show it. But I've never had anybody. I've got a guy right now. I'm representing him. I made a book. This is his book of his drawings. He's been in 1 year and 7 days past his parole date. He was paroled April 6, 2023. He is still incarcerated. He has nowhere to go. So I'm asking you definitely to dedicate some funding to aftercare services for people with disabilities, because it's a hidden secret. They're not able to advocate for themselves. Jonathan is going to draw his way out, and he represents lots and lots of people who have this disability or similar ones. I'm just going to read you one thing of his. He writes letters. He's given me permission to share this with everybody as much as I can because he wants to help other people. There's a long gap of time with me trying to kill myself from age 5 of me taking my sweater sleeve and tying it around my neck and the other sleeve to the handle of the gym door and trying to kick it to choke myself, all in response to being laughed at by the others when I couldn't play what they played, hopscotch. There are so many people incarcerated that have these stories. They might not always have childhood records so that the Office of Developmental Programs will let them have services. A lot of people with this much disability. If I sent you home now and said, find me your 4th grade report card or you can't have a mortgage. To me, that's very similar to what happens. People cannot get the help that they need. He says, my questions are very different than yours. He's letting me know his counselor says re-entry is not working. There's one here. I'm not afraid to die, Mrs. Randall, but I am afraid to fail. So if it means continuing in what's here, he's got an offer to kind of leave and go to a different unit. If it means to continue to stay here and sacrifice myself so that awareness is made and this doesn't happen after me, then I will see it through. I'm sure you know the quote, no sacrifice, no history. He writes about things that have happened to him from sometimes from staff. There are great staff at the NRTU in Albion. We've met them. They conduct really interesting programming. They've self-selected. But like every other discipline we've ever worked, hospitals, schools, wherever, there's always going to be somebody who finds it really entertaining to find somebody with a vulnerability and see what kind of behavior will happen if they bang on themselves so hard that paint comes off. He's got some really, really challenging things happening. I've found, and I'll try to wrap up here, I never thought in my career of helping little kids, my best friends would end up being prison rights attorneys, but that is absolutely true. Speed dial, they're here. I don't think it should take lawsuits or deaths or injuries to make this positive and to be humanistic about this. So I'm really hoping, as I talk to people at DOC, and I say, what do we need? They would like to have contracts for people like me, for other people here, to come in, help design the units, help train people consistently, and help design re-entry and provide re-entry housing and services. There is nothing if you have a disability. So I guess to the credit of the DOC, they're not going to put people into random programs because they don't believe that they'll do well. They might actually decompensate, but then the alternative can't be to stay in for a year and 7 days after parole and have people think. He constantly asks, what is wrong with me? He got paroled and he left. What is wrong with me? This is a person who's been suicidal since he was 5. And he's not the only one. He's just the only one that has the voice and honestly the artistic talent to get our attention. So I'm here to ask that we continue the conversation, that I meet with people I've met with before here, to maybe we do, I don't know if you can do a subcommittee on this or however this works. That's not my job all the time. I'm the humanistic person, not the politician. Yeah, but thank you for your time, and thank you for your future time so that we can continue this conversation as long as we need to.
Okay, hang tight. Thank you, Lou. Lee?
So first of all, good afternoon, and thank you to good afternoon, and thank you to this distinguished panel of legislators and to this audience and to my fellow testifiers who work on these particular issues. Again, my name is Lee Owens, and I serve as the Education and Advocacy Director for the Pennsylvania Prison Society, based out of Philadelphia, but doing work across the state of Pennsylvania. And first of all, just pardon my voice. I'm recovering from some sort of allergy or sinus attack that has, tried to kill me, but I'm here. Thank the Lord. But it's great to be here with you guys. So I always like to start off with a little bit of history regarding the Prison Society. The Prison Society was founded in 1787 by this country's founding fathers. Benjamin Rush, Benjamin Franklin helped found the Prison Society out of the notion that when a person is incarcerated, that does not mean that they don't deserve certain things such as dignity, safety, and basic human rights. And to this day in 2024, the Prison Society still operates out of that notion that neighbors should be checking on their incarcerated neighbors. So that said, the Prison Society handles thousands of requests every year based on our prison visits. So we're probably the only prison monitoring organization in the country. There are some organizations that do similar work, but in terms of the Prison Society's very unique access to county and state facilities here in Pennsylvania, there is not an organization in the United States that has that sort of access to Department of Corrections facilities and county level facilities. So with that said, we see a lot of things going on behind those walls. And I'd like to just share some of those case studies with you, and maybe start off with just a few statistics, and hopefully I don't overlap with what my colleague here said, and that actually might happen. But our work does very much align. So we found that about 80% of women and 65% of men in prisons, and 50% of women and 40% of men in jails do have a disability. Now, I want to kind of just elaborate on that a little bit because when we, and I'm sure this has already happened, we've defined what a disability is, I'm sure throughout this conference, but in terms of, how it relates to being inside a correctional facility, I think we found that not everyone immediately identifies as an individual with a disability. And so what you'll find is that individuals with intellectual disabilities, individuals with maybe even autism in some cases that has gone unchecked and undiagnosed, and in many cases has led to that incarceration. You'll find that once they're behind those walls, it's still not identified, and it manifests itself in very different behavior than what you'll see other people act, right? And so that in a lot of cases makes that individual the focus of attention, usually negative attention. So despite this sort of high prevalence, disability and deafness, which we also consider disability in prisons, is a very understudied issue, and much of the available data is quantitative. Okay, and so I want to also just say that we get thousands of requests, whether it's by email, phone. We get people that walk in, family members that walk in and want to talk to us about the individual situation that their family member or friend is dealing with inside. I personally get text messages, sometimes from legislators, sometimes from community stakeholders that know people that are incarcerated that have, very specific issues with their loved ones. And a lot of those, I would say, upwards of 80% of those inquiries and those requests have to do with access to healthcare. And even higher percentage of that healthcare relates to specific disabilities. So a subset of the letters and calls we receive result in requests of monitoring visits. So they request that we come in and kind of take a look and see what's going on in that particular facility, not just as it relates to a specific individual situation, but overall, and how that situation might play into any sort of systemic issues that are going on in that particular facility. Based on our 2023 monitoring request log, through the end of September, roughly 10% of our official visit requests included a disability-related issue. And to give you just a hard number, so out of 1,829 requests for a visit, 188 of those particular requests were regarding a disability. And so 70 of those particular requests for people incarcerated, were from people incarcerated in Western Pennsylvania. Some of these requests stem from untreated injuries or healthcare conditions. So, for example, one incarcerated person discussed how for years he had been having severe untreated pain on the whole right side of his body. The pain made it difficult for him to sleep, relax, see, and get exercise, and even do simple tasks like brush his teeth. We also noted that chronic conditions such as diabetes were worsened by lack of access to consistent medical care inside the facilities. So another case study in August 22, at the request of the Allegheny County Jail Oversight Board, we conducted a facility-wide survey of county jails, particularly Allegheny County Jail's 1,800 residents. And it was called the Prison Life Experience Survey, and it was completed by over 20% of the resident population. Out of 422 narrative comments submitted, 7 mentioned disabilities. 5 of these are related to mismanaged chronic medical conditions. We found that incarcerated people and their families often reach out regarding lack of consistent care for chronic illnesses such as diabetes or epilepsy, deteriorating a person's health and leading to more severe disabilities. This is an area where our monitors actively advocate for access to proper medical treatment. So far this year, a mentoring program that we run in the southeastern part of the state has supported 74 men transitioning home from prison. In one recent case, a mentor had never met his mentee in person and learned several weeks before his release that he was in a wheelchair. So the mentor had to jump into action very quickly to look for ADA housing options for that individual in the county his mentee plans for him to return to. So that kind of quick thinking is something that, it happens pretty often, right? We don't always hear about it. And so because their relationship had been built over the phone and via email, if the mentee had not volunteered his need for an accommodation, the mentor would not have known to focus his efforts on an ADA compliant housing option. Going forward, prompting participants to list any need for accommodation will better prepare volunteers to seek resources for mentees with disabilities. So it's kind of like we're still learning as we go. Because of a situation like that, we can put different questions on our surveys and say, like, in terms of like intake, like, do you need special access because of a disability? And we've also found that, like, I think you even said this, like, it's okay to ask a person if they have a disability. And in fact, that's something we probably should be doing. It's not offensive. Other things are, but I don't think that is. So, we work with other organizations. Some of them are here today. The Abolitionist Law Center is one I'd like to highlight, as well as the Disability Rights Pennsylvania. Another thing we found is that a disability might not have arisen as an issue when we were first contacted by that individual or their family. But once we do that visit or once we meet them in person, we might find that there is a disability there. And so we can dig in and kind of pull out what that disability might be with the help of staff. So let's see. So another shared challenge is that disability accommodations may be granted at one facility, but if a person is transferred, they need to go through the process again, which generally is very, very slow. And just to give you even a little bit more context to that, you'll find that an individual, say, may come into intake when he's first put in custody, and say, for example, he has a cane to help him walk. Most times that cane is going to be confiscated because it's considered contraband, and then there's a lengthy process that he has to go through the prison health system in order to get a replacement cane or whatever they're going to give him in order to help him walk. So those kind of situations do happen pretty frequently, and it even comes down to, like, we've heard stories about, mental health medication that they're trying to access while they're incarcerated, that they can get sometimes but not consistently. And then during that intake process, sometimes there's a substantial gap in when they're able to get their hands on that mental health medication. So let's see. I also want to highlight some good things that are happening in the Department of Corrections. Don't do that. So the Allegheny County Prison uses telepsychiatry to access mental health conditions, and they do have a designated autism specialist. So I would like to highlight that because that is something positive. Autism Connection is currently working to create a task force dedicated to advocacy for people with developmental disabilities in prison. So that's some really positive work that's happening in the areas of autism specifically. But I think we have to be clear that there are a lot of disabilities that don't sort of have that spotlight. And that goes down to, again, we're talking about mental health issues that many of which have led to that incarceration, communication problems, just a whole slew of unchecked mental health disabilities, intellectual disabilities. So as I close out, I would just like to focus on a couple of specific case studies. Recent case studies. There is a gentleman right now in Allegheny County that is unable to read or write. The prison will not help him at all. He keeps getting denied parole, and his family believes it's because he's signing things that he cannot read. He's been incarcerated for many, many years. He can't get a job because no one will help him fill out the application that he cannot read. So I just wanted to highlight that particular situation because illiteracy is, I guess you can consider that an intellectual disability, and it's very prevalent within county and state facilities. And you'll find that even as it relates to access to the electorate, voting while incarcerated, you'll find that illiteracy is a very high level impediment toward an individual being able to take advantage of the franchise. Mr. Topper is, and I believe he is in SCI Cole Township right now. Mr. Topper is wheelchair bound, can't talk or walk. And he's been trying to maneuver the prison and basically at the good graces of other incarcerated people because he essentially has, no institutional support outside of the prison society. And we're actually currently working on this case right now. So when he talked to our helpline advocate, he was exhausted, but he was able to let them know that he had threatened to kill himself because he had it with the correctional officers and the staff not recognizing his medical health conditions, his needs, and particularly as it relates to communication and him really being able to articulate what his needs in fact are. So his wheelchair is broken, and even though he goes to the weekly wheelchair check, the missing screws on his wheelchair are duly noted, but the people doing the weekly check insist that their job is only to look for security issues and not order repairs. This has been going on for weeks. So the refusal of the prison to approve the use of communication devices, such as the Ubi Duo, in situations like group programs for an individual that can't communicate. This is a tool that it's like a booklet or something they're able to use to communicate to individuals. So the alternative would be for Mr. Topper to use a lamented communication booklet to participate in his group. But to use the communication booklet, the group leader would have to stop the program, physically go over to Mr. Topper's place in the group, and watch him point to letters until he communicated his thought. And unfortunately, and understandably, they're pretty much unwilling to disrupt the group in that way. And I understand that. So inhumane, pardon me, I'm getting ahead of myself. So there is currently no ADA required communication booklet while Mr. Topper is in POC or RHU. So his booklet was taken away from him and returned to his cell back at the RTU, solitary. Without a communication device, Mr. Topper has no way of communicating. He cannot even communicate a medical emergency. And he's in solitary right now because I believe that it was overcrowded in the general pot where he was. So he didn't do anything wrong, just for context. And so since the bed in the RHU was against a back wall, guards told Mr. Topper he would have to crawl to the door to get his food tray. Mr. Topper, because he doesn't have his wheelchair right now. Mr. Topper refused to crawl as he felt as though they were treating him like an animal. His wheelchair was confiscated when he had to go into RHU. So he refused to crawl as he felt as though they were treating him like an animal. And of course, he is absolutely no security threat as his limbs and body are severely weakened due to his illness. As it turned out, the director of psychology, Dr. Goss, has interviewed Mr. Topper, interviewed him that day, and requested that he be examined. This was the first time that Dr. Howard had seen him, even though he has been at the facility since June. The doctor immediately realized that the medical record notes that he was faking his illnesses was wrong, because I guess he was being told, folks were being told that he was faking his illness. They assessed him and decided that he was not faking this illness. And he was transferred to SCI Camp Hill. So in January of 2024, we visited him at SCI Cole Township. He had not been receiving his medications as needed. And so the saga continues. I believe that was the last note in January of 2024. But this is an ongoing saga.
Thank you, Lee.
It's my pleasure.
Sounds like things are going great. So, look, I appreciate it very much, and I want to pause just because I'm going to run out of time. I got to get to the three others, and I want to be sure that we can have a moment to ask questions. I also want to just take a second. I had said that somebody who's being sued. It wasn't the individual, it was the state being sued. So I do want to correct that. I didn't mean to say the gentleman was being sued. Lou and Lee, thank you. I'd like you to hold tight because I want to see how we can get to questions, but I got to pull the other three up too. Okay, so give me thank you very much. Appreciate your testimony today. We're going to go right in. I'm going to ask Jason Beeson, who's the Chief Deputy Warden in Allegheny County Jail since 2021, to join us. He's a member of the Pennsylvania Prison Wardens Association and Pennsylvania County Corrections Association. He's joined by Renee Madden, who's the Deputy Health Services Administrator of Behavioral Health at the county jail since March of 22. In that role, she oversees the Behavioral Health Department. As a licensed social worker, she enjoys she enjoys bridging the gaps and working with people during the most challenging time of their lives, which we appreciate. So thank you both. I think, I apologize, is it Deputy Warden?
Deputy Warden's fine, sir.
Yeah. What is it? You got a captain too? What is a rank? Is there another rank?
Chief Deputy Warden.
That's the cool title.
That's the rank.
All
Yes,
right.
sir.
All right. Sorry. Thank you very much. Go ahead.
No, thank
Appreciate
you.
it.
Good afternoon, ladies and gentlemen on the panel, and we wanted to thank you for the opportunity to present to your panel today. As Representative Miller said, my name is Jason Beeson. I'm the Chief Deputy Warden for the Allegheny County Jail. I'm going to start by providing some data regarding the facility before turning it over to Deputy Health Service Administrator Madden. The Allegheny County Jail opened back in 1995. The facility itself is 1 million square feet, and it has 16 levels, which contain 35 different housing units, okay? Our maximum capacity is 3,223 inmates, with our current count averaging between 16 to 1,700 inmates. Today's count is 1,687. We are a booking center for 130 local municipalities in Allegheny County, as well as state and federal agencies. In 2023, the Allegheny County Jail booked in 9,059 individuals and released 8,746. And keep in mind, those numbers do not account for the individuals who were released after arraignment. So they either received a non-monetary bond, a release on recognizance, or received a bond that they could satisfy before we began the booking process. Of the 35 housing unit I mentioned, we have 2 acute mental health units for males, 1 acute mental health unit for females, 1 subacute unit for males, and 1 step-down mental health unit for males. As I mentioned, our current daily population is fluctuating anywhere between 1,600 to 1,700 individuals weekly, and of that population, 75% of those are on some form of mental health medication. So that is where Deputy Health Service Administrator Madden and her team provide necessary and meaningful care, and she'll continue the report to discuss that.
Thanks. So looking at some patterns in 2022 and 2023, we had coincidentally the same top 3 mental health diagnoses, which were PTSD, number 1, anxiety, and depression. And that was the same for both years. And like Chief said, we do see a range of different diagnoses and a lot of patients who are on psychotropic medications throughout the jail. And so speaking a little bit about our process, so right from intake, before the arresting agency leaves the building, we're already assessing for immediate needs, suicidality, acute needs. We look for active 302s, any reason where we may need to send a patient out to the hospital before we keep them, and that's medical too, but I'm focusing on the mental health side. And so after that point, there's additional screenings that happen, and at each one, they're assessed again for those acute needs. Once a patient is booked into the facility, we use a full mental health screening, and at that point, we assess for their psychiatric history, if they've had any hospitalizations recently or ever, along with suicide attempts, and what medications they're on, and we gather all that information from them. That also helps us determine their housing. So right from intake, we're looking to see if they need to be on any of those mental health housing units that Chief spoke about, or if they're able to go directly into general population with either a priority psych referral or a regular psych referral, or there are people who don't need one at all. And then upon admission during that intake process, we have some different partnerships with DHS and ODS. One of them is like an automated list for bookings. If someone who is already registered becomes incarcerated, we'll get that sent directly to our email once a day in the morning. And then we have those connections with them. So we reach out, or oftentimes they reach out to myself or my team and say, this patient that's registered with us is now booked and incarcerated with you. They provide us their med list, any coping skills or any treatment things that tend to work for them, so that we can put that right into their treatment plan. And it's very helpful for us, because then we can use that with them while they're with us. And then upon discharge, for those patients who are already connected, we have a point person, and we can make a home plan and coordinate their needs upon release from the jail. Throughout incarceration, the psychiatry team can meet with patients, and they will do the medication management. Our psychiatrists, they cover the acute units and the juvenile unit, and then our advanced practice practitioners, psych NPs and PAs, they cover the rest of general population. We have mental health specialists who are master's level prepared clinicians who can respond to crisis calls. They can do psychoeducation with patients one-on-one or in group settings. And something that we're working on right now is building out a program for therapy. So we would like to have a total of 12 therapists that can provide individual or group psychotherapy for patients who are eligible for that service. Some of the barriers that we run into with patients who have SMI or acute mental health needs are upon discharge. So if we have great rapport, and we appreciate this with the court system, if we identify a complex patient or someone that we know is better served outside of the jail, we'll reach out to them, pretrial services in the court system, and they're good about agreeing to a plan, but there's often not a placement that we can place the patient in. So we run into patients waiting much longer who have higher needs for long wait lists, or just in general, just not enough places for them really to go. So that's a big thing that we struggle with, and we know the patients do tend to decompensate once they're within the facility, and we can manage their symptoms with medications, but we also recognize that they would just be better served outside of the jail. We also have a number of patients who are waiting for Torrance State Hospital, and they serve over 40 counties. They only have so many beds, and so our patients do end up waiting anywhere between 4 or 5 months. Recently has been the amount of time it takes to transfer, and then they can have the competency restoration services and then return to the jail and proceed with their court hearings, and that just adds more time for them to be incarcerated. So just overall, really thinking about what would be helpful is more of those forensic involved beds and community placements, so we can get patients out of the jail more quickly and into the most appropriate placements. And that's ranging from psychiatric hospitals to all the way to like group homes and living placements within the community. And then on the other end of that, really looking at more community diversion efforts. There's not really any option. Usually, the patients have to come to jail first. So if there was something where they could be housed elsewhere while they go through that, process, would be also very helpful. I think that jail often ends up being like a last resort, almost looked at like a treatment option for patients. But again, we recognize that they need to be served elsewhere. So thanks for your time.
Thank you. And I want to again thank the county. When we reached out, we are obviously hoping to have a state component to it as well. That couldn't work out given the court case. And so I also want to recognize that you guys came, you're talking. The county executive was very kind in making sure you were here as well. We definitely appreciate that. So I'm going to try to ask a couple questions more. Not just ACJ, but sort of like just county facilities in general. So I guess like first, just a couple of quick things with it. You guys have just over 1,000 people who are in there today. Do you guys know on a given date, for example, how many of them require behavioral health supports?
I think the average tends to be about 75%. It needs some type of intervention. The acute intervention is much less than that, but that would just be like our general average.
Okay, and that fits, the last time, again, I was there and talking with the warden, I think he suggested 80%. So something that's in that ballpark. But the answer is yes. You guys know exactly who has a behavioral health need in your facility.
We can run reports to find, like right now,
Not
no.
you personally,
but
but you guys know.
Yeah.
Somebody can spit out the number. If I ask for it tomorrow, you guys can print it out and say, here's the number.
Yeah.
Right. And are you guys able to spit out what the diagnosis is? You track the diagnosis?
Yeah, yep. So it's all through the electronic health record. And so that's all, individualized, and any diagnosis a patient has would be added to their chart.
Besides from providing medication, what's the other therapeutic side that you guys are able to do?
Yeah, so that's what our mental health specialists, those master's level clinicians, they can do crisis calls or just general follow-up with patients, and that's more around psychoeducation, which would be coping skills, distress tolerance skills, really whatever the patient's struggling with, they can support that.
How many of them do you have?
Mental health specialists,
Yeah.
do we have? I think we have 9 right now.
Okay, so if
across
we're
all
running
shifts.
about 70%, let's just go with that number, and let's just say it's 1,000. So you guys are running 700 through 9, right?
Mm-hmm.
Is that good?
Yeah.
Yeah?
What do you mean by is that good?
Is that the ratio that you find to be appropriate given the level of need for the people you're serving?
Oh, no, we could definitely use more people.
So it's not good?
Absolutely, not good.
Not good.
Your math was good.
Math was good. Yeah, no, I know that. I worked it out. No, I didn't. Okay, Rep. Steele.
Just a follow-up question on that.
Yeah.
So are these people that come in with the diagnosis? Because I think that probably a lot of these people don't come in with a diagnosis, but there's an opportunity for them to receive a diagnosis while they're there.
Correct, yes, it's both. So some people will come in, and with our community partners, a lot of times we receive their diagnosis when we receive their med list. But then there's also patients who maybe don't know or underreport, and then when they're evaluated by our team, they may be given a diagnosis.
So is everybody evaluated by a psych team?
Not every single person, only if there's an indicated need. So it's not only for patients who request it. Our team can observe symptoms or a reason to maybe check in with that person. So it could be a staff referral, officer call, or a self-request. But
because to me, if you're finding yourself in a facility like this, that probably in itself would warrant some kind of, assessment.
Sure. Yes, everybody that comes in through the door gets that initial assessment, and that's by the master's level clinician. But the psychiatry team is what I was talking about, would be through referral or self-request.
Rep. Avni.
Thank you. So kind of on that note, you talked a little bit about your intake process and the screening for mental, intellectual, or behavioral issues that folks might be experiencing. Is that intake process, the step-by-step process, are you mandated by law to do all these things, or is that germane just to ACJ? And I ask that question because I think about a different person's experience at a different jail, right? So if you were doing this, but I get locked up in Beaver County Jail, I'm assuming they have a jail, but another county jail, am I going to get the same type of attention in terms of that intake process and that screening at a different jail?
Yeah, by law, I think no. We go by our standards. So we're accredited with ACA, we're working towards an NCCHC standard, and so we follow those guidelines of what screenings must be completed and at what frequency. So I think each jail would likely be a little bit different, but yeah.
So like DHSA Madden said, we're ACA accredited, so their standard is those assessments have to be completed within 14 days of admission. Okay, so we far and exceed that by completing that in the intake department before the individuals are even sent upstairs to a housing unit. But what the other county jails do, we couldn't speak to. It would probably depend on their accreditation level.
Rep. Kincaid.
You looked over there and said my
No, I know
name, and
where
I
you
was
are.
very confused. You guys have spent a lot of time talking about mental health and mental health screenings, but I mean, a lot of what we talked about in the last panel was also disability and sort of a lack of screening for disability and accommodations on that end. So I'm wondering where disability falls in these screenings and how comprehensive you guys are in terms of making sure that people who need accommodations have them, whether or not they can advocate for them themselves.
Sure. So embedded into our mental health screening, there's questions about intellectual disabilities if you've ever been diagnosed with one. And that information is all gathered during that same assessment. Generally, if we notice that a patient, either they self-report or again, we see signs or symptoms, we will house them on our mental health housing units. So to us, it's just kind of together. And then our psychiatry team can see them. And then typically that allows us time also to get records and see if they've been registered like through ODS. And that's where we inform their treatment plan. But we don't have them go straight to general population. We will take them on the mental health housing units.
Thank you. If someone told you they needed anxiety medication, that they don't have their anxiety medication, how long would it take for them to get the anxiety medication?
Yeah, good question. So during the intake process, if you have an active script, we run a Sure Scripts report, and it's been filled within 30 days, you automatically get that medication, same dose that you're on, because we can see that you've been taking it, and that's something that
And then we'll follow
they'll
them when
get
they're
it.
released. They can have it on the way out the door.
Yep, so then they're followed throughout the jail. They'll be seen however often the doctor needs to see them.
And I want to thank you because I got to jump with it for our last one as
Okay.
well. Last question for you, Deputy. Rank the county jails as to which one's worse. Go, Western PA. Now, all right, we'll let him go for that for a moment. Thank you. We'll pick up on that for another time. Our last speaker, who we have to get to because we want to hear from him, the last speaker of the summit is Alec Wright. He's a civil rights attorney at O'Brien, Coleman, and Wright. His representation includes matters like police misconduct and systemic constitutional violations. He also represents clients on prisoners' civil rights issues such as abuse, mental health, and inadequate medical care. Thank you, Attorney Wright, for waiting so long to talk to us, but we definitely appreciate hearing from you, so please. I'm sorry, nobody wrote down Melinda. I would have said Melinda, but thank you, Melinda Murphy, as well. I apologize.
That's all right. No problem. Melinda is a much better representative, somebody who can give you information because she had a son that went through, has autism and went through the process with the state correctional institutions. She is who I would recommend that you listen to the most above anybody else that you've listened to because she's a parent of somebody that she loves who had to go through this process. And so I would defer to her if and she's ready to speak. So let Melinda talk to you first, if that's okay.
Thank you. Thank you, everyone, for being here and for allowing me to be here. My name is Melinda Murphy, and I come before you today on the 3-year and 1-day anniversary of the day that my autistic son was arrested and incarcerated. He is still incarcerated at the state level here in Pennsylvania today. Ethan was diagnosed with autism at age 6. He also has several other comorbid diagnoses, including major depressive disorder, anxiety disorder, as well as ADHD. When Ethan was 8 years old, he made his first attempt to take his life in the elementary school bathroom. He tried to hang himself off of the hand towel rack due to the bullying that he received because of his disability. Suicidal ideation would be a constant problem throughout of his life and cause several hospitalizations for him. In April of 2020, my son was laid off from his job in the oil and gas field. He was working that job to save up money. He thought it was the fastest way he could save money to go to college. In the summer of 2020, Ethan self-elected to undergo electroconvulsive therapy in hopes it would help him with his major depressive disorder. During these treatments, my son became nearly unrecognizable to me. It severely altered his personality. During this time, he also reconnected with a girl that he had graduated from high school with, a girl who was aware of his disability. She preyed on my son's being socially naive and She convinced him that if he would conduct illegal activity for her, she would be his girlfriend. And even though this went against my son's moral compass, the need of wanting to fit in, to be accepted by his peers, seemed to outweigh the dangers. So the potentially deadly combination that my son was experienced at that time with the electroconvulsive therapy, as well as starting to abuse substances, ultimately led to his incarceration. This is the first time that my son and our family have had any sort of interaction with the criminal legal system. It's been very eye-opening, and honestly, it's been more like a gut punch than anything. We hired private counsel, exhausting all of my son's college savings. This attorney met with my son one time, and that was so he could sign a power of attorney so that I could handle my son's financial obligations. The attorney also told us not to mention my son's disability, as it would, and I quote, make the judge think that my son was even more of a monster than he was already going to. I clearly did not agree with this, and I argued the important role of the manifestations of my son's disability and how they played into his charges. I collected letters of support from a therapist, from our family members, and the day before my son's sentencing, his attorney received an email from the prosecuting DA that said if we submitted any of these letters, or if I spoke of my son's disability, the plea deal would be pulled at the day of sentencing. My son signed a plea deal that he did not even fully comprehend that is going to impact his life for many, many years to come. A wise man once told me that Lady Justice is supposed to be blind, but she isn't supposed to be stupid. The way the criminal legal system is handling people with a medical diagnosis of developmental disabilities is nothing short of abusive and neglectful. The fact that the Pennsylvania Department of Corrections is the #1 mental health service provider in our state speaks volumes to the failures of our community-based mental health and autism intellectual disability resources. Further, and because the prison system was never designed to be a psychiatric hospital, DOC facilities are ill-equipped to provide appropriate autism and mental health services for the individuals behind their bars. Sorry, a little bit nervous. That being said, I will not fail to applaud the Department of Correction and them recognizing the need to establish the Neurodevelopmental Residential Treatment Unit at SCI Albion. The unit is specifically designed for individuals on the spectrum. The staff in the unit receive special training to learn how to work with these individuals and their disabilities. There's many disability appropriate accommodations made in this unit, including staff-led programming, a sensory cell where an inmate can go when he's feeling overwhelmed and needs to decompress, an intentional low number of inmates housed in the units. This allows for a lot less stimulation, as well as the staff being able to provide more individualized care to the individuals there. They put blue coverings over some of the fluorescent lighting to help with sensory issues. They do in-unit medication delivery, and the inmates in this unit also have their own private yard so that they do not have to go out and navigate and intermingle with the rest of the general population of the prison. after a referral process, an interview, and myself providing literally my son's entire life's record of mental health and autism, you know, all of his mental health history, my son was chosen to be housed in this unit. And it was a really great thing. And he was really healing. I saw so much just personal growth and insight from him, from the, you know, the programs that he was receiving. And even though this sounds like a really odd place to find such a thing, for the first time, my son felt that he had really, truly established friendships with the peers that were located there in his unit. Sadly, in June of 2023, my son's estranged stepmother took a position on the administrative side of the facility, and due to a Department of Corrections policy of safety and security, my son was forced to transfer to another location here in our state. He has lost all of his disability accommodations. His mental health is severely decompensating, and he's regressing back into old thought patterns. I'm desperately trying to change the mind of the Department of Corrections, and not an easy thing to do. They're sticking to their policies. So prisons are...
You know what, just, you know, are you representing her at all? No. Do you have an attorney? No. Okay. You know, look, hold on. Just like reach out, okay, and we'll do a letter, okay, assuming what you're telling me, you know, is accurate thing, okay? We'll do a letter. My feeling is a lot of my friends will sign on to this letter, okay, and we will try to add some more weight to your son's situation, okay?
Thank you.
I will also add that, so I'm on the board of the Prison Society, and Lee is also somebody to talk to, and I think we can absolutely get the Prison Society activated around that. One thing that I don't think the Prison Society does is acknowledge the fact that not only are they statutorily authorized to oversee things, they are constitutionally authorized to oversee our prisons. And so they're an incredible service. So I'm happy to help you with that too.
Yeah, let's just move though with some speed on this, you know, so I mean, it's,
Yes,
what is it, the 19th? So like, let's just get this done next week, all right? So like, you know, but reach out. We need some information, okay? Want you to go to my staff on the way out, reach out. We'll work on a letter, we'll team it up with Lee and anybody else who wants to help with the thing, okay? And we'll look to get it done by this time next week. We'll send it in and we'll see what we can do.
Thank you.
Okay.
Thank you so much. I appreciate that a lot.
What else can we do?
I would like to say, I will wrap it up quickly here. I apologize. So countries such as England and Canada and Australia are very progressive in how they're handling justice-impacted individuals with intellectual and developmental disabilities. Here in our own country, the state of Virginia has made tremendous strides with passing several legislative bills addressing this dire issue. They require the Department of Education to establish age-appropriate sex education to be included in the IEP process, to defer deposition, diversion programs, as well as dismissal of some criminal cases when appropriate. The state of West Virginia has just recently, in 2023, they introduced legislation to see how they could best solve this problem of people with these disabilities coming into their system. In 2024, they passed another bill to continue that study, as well as looking at funding options for diversion programs for this population. And then in the state of Nevada, they have actually established an autism court. They primarily deal with juveniles, but it is established there. And I feel that with the existence here in the Commonwealth of already having specialty and problem-solving courts, maybe something like that could be an option here, along with Justice Doherty's Autism in the Courts initiative. So I think we kind of already have, maybe some wheels moving in that direction. I've included links to this information in the package that was provided to you if you would be interested in seeing any more of that. And I think that to remain as cutting edge as the other states around us, that Pennsylvania could step forward to enact legislation that could create diversion programs to community-based resources and therapy in lieu of incarceration for these individuals. I know we have looking at a DOC budget of $3.3 billion. They say they only have 36% of their inmates have mental health diagnoses, but maybe money could be diverted from there somehow and into community-based resources.
Okay. Melinda, I want to thank you for that, okay? And we do have your information as well. I'm going to run short on time.
I know.
But what I want to do, and I want to thank you, I want to hear from the counselor as well, just so we want to hear what he has to say here towards to sort of bring us home with this here. So I'm going to ask you, if you don't mind, if we can.
That's fine. And
Yeah.
I just want to say one more thing. I just believe that as a society and as Pennsylvanians, we can do better than locking up the most vulnerable members of our communities.
Thank you, Melinda. Counselor.
I stood correct that Melinda has more important stuff to tell you than I ever could. But we heard from the Allegheny County Jail, and I deal with disability and deaths and bad things that happen in both the state and all county and local jails across this Commonwealth. When we talk about the Allegheny County Jail, let's not forget that since 2015, there's been nearly 40 deaths at that jail, and not a single mortality review has been conducted with respect to one of those deaths. Since 2020, from a period of 2020 to 2022, there have been 19 deaths. 17 of those deaths are believed to have been with respect to individuals with disabilities. So in my limited time, let me tell you a quick story of how an individual named Anthony Tallada, who is involved in active litigation against the Allegheny County Jail, came to die there. He was an individual who was autistic, intellectual disability, has anxiety and depression. And the reason why Anthony's story is so important, because he was adopted from Italy as a small child. And before his adoptive parents knew it, he had been diagnosed with autism. Things were clearly different with him since a very young age. And his mother, who didn't work, decided to get a job. And his mother worked every single day for the rest of her life, scraping every penny that she could and put it into a special needs trust fund for Anthony. And over her life, she was able to generate almost more than $1 million, $1.2 million into a special needs trust fund. The sole reason why she did that is because she understood that when she died, government, society, there was going to be nobody else that was there to take care of Anthony and love Anthony the way that she did. And when she died, family did the best that they could to take care of him, but Anthony went from group home to group home. He had typical manifestations that center around individuals with the disabilities that I've mentioned to you. And ultimately, Anthony was engaged in an altercation at a group home where a pot of boiling water fell on his foot, causing severe burns to that foot. He was taken to the Allegheny County Jail. There was no diversionary program. There's nowhere else to send him. The place that he went was to the Allegheny County Jail. And what the Allegheny County Jail did was hire a doctor by the name of Wilson Bernales, who had his license suspended or revoked at least 15 states that we know about. And that was the individual charged with caring for Anthony Tallada. And when we talk about policies and how well it sounds to say those words out loud, policies are only as good as their implementation. And the NCCHC is the gold standard of correctional care that is provided in jails and prisons. Those are the standards that we abide by. And if you look at the audits, if you can call them that, from the NCCHC, because that would be a misnomer, you will see all of the warning signs that were provided to the Allegheny County Jail on what they needed to do and what types of corrective action they needed to take. Anthony was diagnosed with 3 active infections in that foot. And you heard about the mental health unit and things like that. Well, that's exactly where Anthony went. The crutches that he had were taken away from him. The assistive device for his foot, because he was non-weight bearing, was taken away from him. And the reason for that is because he had a disability and was sent into their disability housing unit. As a result, he was prohibited from accessing the medical housing unit. The way that sepsis works is when you have an infection, the bacteria goes through your body, it gets into your bloodstream, and before you know it, that you have to act. Your first sepsis, then you become severely septic, and then you go into septic shock. And 2 hours before Anthony's death, he was severely septic. He was examined in the housing unit where he was with no access to the medical housing unit, and he was given a shot of Benadryl, told that he was allergic to the medications that he was being provided. He was shuffled back into his cell, where he was found foaming at the mouth, convulsing on the floor, 2 hours later, dead. The Allegheny County Coroner's Office would declare that death to be a cardiac arrest natural event. Do not be fooled by categorizations that you see with respect to autopsies, because there are only 4 specific categories that can even be given to them. Anthony died from sepsis. He died because he was autistic, had an intellectual disability, had anxiety and depression, was placed in a housing unit where he couldn't care for himself. Something that you should all take note of is an act called the Prison Litigation Reform Act. It's an act that requires you to exhaust all administrative remedies before you can file a lawsuit. Should you fail at any step of the Prison Litigation Reform Act, you cannot file a lawsuit subsequent to any event that harms you. And if your injury is only mental health, you're prohibited from seeking damages. You have to have a concomitant physical injury. Attorney's fees are severely limited, and there are other restraints and prohibitions to be even able to file in court. The person that was tasked with being his own advocate was Anthony Tallada in that jail. He had an intellectual disability. He was autistic. He couldn't tell anybody that he had an infection in his foot, that he was dying. And I know we're running out of time, and that we are out of time. But these are not isolated events. I don't know what you can do. I don't know what to even ask you for. I was asked here because a friend asked me to present. But the front lines of where this stuff is fought is in a courtroom and trying to make sure that things are in place to win lawsuits and push the needle forward. To the extent that you all can take up a pen and fix it and get on the front lines and do that, there are people that are suffering every day in the incarcerated population that everybody else you've heard from are being sent there because there's nowhere else for them to go. So I hope something is done.
Thank you, Counselor, and thank you all our panelists for their expertise. Obviously, we are at the end, and so I very much appreciate it. And I know that we asked a lot of everybody to prepare for time and testimony, and then it goes quick, and you end up running through things. You almost wish you had another hour for it, of course, right? Look, the reality, I always remember being at a town hall with my friend Ed Gainey. And I made a comment where I said that the justice system wasn't broken. And I got booed. And I said, no, it's not broken. It's doing exactly what you designed it to do. And so here, look, one of the challenges that we have to realize is that what is left of our incarceration system is largely a bunch of people who have a diagnosis. And that we've not prepared the system for it. There are 70 to 80% of them going through it even a bunch of professionals who are in the system, correction officers and others, know that it doesn't work as well as it should, because we're trying to get a square peg in a round hole in a system that really is some weird hybrid, because some people are talking too much about some sort of understanding or weird or odd understanding about how to address accountability when they're not realizing we're still struggling with a public health crisis, because we allow too many things to fall through the cracks and then expect people with badges to wear 5 different sort of professional hats in that process and somehow solve the crisis that we won't fund. So somewhere in there is where we need to continue to push, and that's going to take more than an hour for us to get to. But I very much appreciate all the stories that people have shared with it here. I want to thank all my friends who were here from Jersey and everywhere else. Thank you very much. Thank you to Bethel and all of our partners who made the event happen. Thank you to all the volunteers and all the sponsors. We very much appreciate it. We'll hopefully see you all next year at our next Disability Mental Health Summit. Thank you so much.